Welcome everyone to ASJ Gems. I'm Phaedra Kress, your moderator, and we're excited to be here with Dr. Douglas Steinbrech today. Dr. Steinbrech graduated from the University of Iowa College of Medicine in 1994 and completed his specialty in plastic surgery at New York University Medical Center in 2004. He is a board-certified plastic surgeon, certified by the American Board of Plastic Surgeons, and is very active on the Aesthetic Society leadership. His passion for male plastic surgery led him to establish the New York Institute of Male Plastic Surgery in early 2016, which provides an educational foundation for current and future physicians to learn about and help further this subspecialty. In addition to his busy practice, Dr. Steinbrech is often called upon to speak both nationally and internationally about his techniques and the unique difference he has implemented in his practice to accommodate the desires and body structures of men. Finally, he has published a book called Male Aesthetic Plastic Surgery with TEMA, which I know he's very proud about. Welcome, Dr. Steinbrech.
Hey, thank you, Phaedra. It's such an honor to be here, and I really appreciate all your hard work with this series. It's fun. Thanks for the invitation.
Okay.
All right, let's get started, guys. So what we're going to, and ladies and gentlemen, so first thing we're going to have to do is wake people up. And if you're listening, we don't want to sweat the technique. A lot of people are really scared about men's plastic surgery and men in general. We'll get into the why for that. But what I like to do is just like I remember when we were at NYU and they were like, aesthetic plastic surgery, oh, it's crazy. It's like it's so difficult. And then you went up to Meath and you went down all 6 rooms. Everybody did it slightly different. And after you went through that 2 or 3 months, it demystified, plastic surgery. I'm going to try and do that for you today. Like, just chill about it. We're going to make these things overly simple. We're not going to make it overly complicated. This is not a lateral canthopexy. So it's going to be okay. Okay. I'm doing this so that you guys start to do it, not so that you refer me all the patients, as a lot of other people do. Okay, a couple of things. We're really proud of our textbook with Dr. S and Dr. Walden. But then TEMA came back, my editor, and said, they're doing all this men's plastic surgery, so we need you to do that. I'm the editor, but all those people in those are right on the cover of the book. They wrote chapters, 68 authors, 48 chapters, and just a really amazing collection of surgeons from all the way around the world. So you don't have to take notes, because notes have already been done for you. You can just, they're all in the book. These are my other disclosures. One of those disclosures is I do order an implant company, but I've used all implants from all different companies. And so I just recommend that you learn the technique. It doesn't necessarily matter what. And the reason why I got involved in the business side of it is because there's such a dearth of good companies and good people that provide products that can help us evolve men's plastic surgery, that I felt that it was a good thing to do. So that's why I did it, really. Okay, we're going to advance. All right, come on. There we go. Okay, everybody during COVID got a little bit hit for 3 months, but then boom, it just exploded. Everybody was really, really busy during that fall of 2020 and into the spring of 2021. But then, boop, like at the end of remember that summer of 22, like things started to drop off a little bit. We all got a little bit cocky. We all thought, wow, we're doing so much women's plastic surgery. Well, there was a push for COVID, and then it came back. But now's the time that you can do a little bit, think about having a little bit more time to do the men. I always try and have something new every year. In 2015, we had abdominal highlights. These are all men's thing. 2016 is body banking. It's just muscle fat grafting, basically. 2017, we talked about catch fat or rebound fat. We talked about doing torso tucks instead of tummy tucks for men. Scarless abdominal sculpting, then a male model makeover to sculpt out the jawline, body bang quarterback and a back lift. And this year we talked about the total torso transformation. So I always like to do something new every year. This is where we were in 2014. Kind of felt like it was the only guy out there, but there's a bigger wave of men's plastic surgery. And so I think you want to catch the wave and be at the forefront of it. It doesn't have to take over your women's practice. You can just add more to it. What do men want? Let's talk about that. This is what we're going to talk about today, the techniques. Why don't we operate on men? Then we're going to get into gynecomastia, a little bit of scarless abdominal sculpting, some body banking or muscle grafting with fat. This is the other half of your liposuction procedure moving forward. Body banking back lift, the torso tuck. We're going to look at biceps and triceps, quads, and then calves, and then finally just for fun, abdominal implants. So why don't we operate on men? That's really the question. It's because we don't have any training. There's not a lot of training in the residency programs. And there's an ego. You want to be the man or the woman surgeon in town that does the best the best facelifts, the breast dogs. You want to be that person in town. There was a fear of blood exposure from the 80s. That was like a big issue. I have 1,000 stories about that. But then the other thing is men are just bad patients. They're difficult. They're, and it's not really true. It turns out by the numbers that men's demand for cosmetic surgery has climbed 325% since 1997. Why do they do it? They want to stay competitive in the job market, look younger, preserve naturally attractive features, eliminate their insecurities, and get encouragement from their spouses or other reasons. Why don't we operate on them? The real reason is we're unfamiliar with them and we have a fear of delivering a bad result because we just don't have an experience. So what do we do reflexively? We're surgeons. We have egos. What we do is we create a boogeyman. Boom. The men are bad patients. It's not my fault. It's not our staff's fault. It's their fault. There's something to be avoided. Don't pick up the phone. Don't answer them. Don't put them on my schedule. All right. What is that guy's name? Is Simon. It's so much. We had to create this so much. So we created even a research about it and called it single immature male over expectations, narcissistic. Everybody remembers this from residency. In other words, just don't operate on men. You may be killed if you do the rhinoplasty, right? You remember that. In my practice, there are great male patients, there are great female patients, there are difficult male patients, there are difficult female patients, full stop, period. All right. So there's been a big boom. We talked about that. Why did I start operating on more men and start doing body bankings? Because I originally wanted patients like this, but I didn't have patients like that. I had patients that came in and they were overweight, a lot of women and men overweight, and then they didn't really go to the gym. So what I noted is I wasn't happy operating on those patients because I would do a really good job to do a nice, mommy makeover, and then I would just see the results when stay with them. And I also saw a demand for the men. When I started my practice, Upper East Side with the 10 million other people on Park Avenue, it was just all crickets. So I realized, there's nobody in there. I realized that when I switched over to the men, that something started to happen. So how can we get more men in our practice by educating them? A lot of people buy all this the Google terms for male plastic surgery, but then once you get to the website, hey, come on, they have butterflies, orchids, so nobody buys that. What you really need is you need to have at least some galleries on your website, right? Doesn't have to be like the last one. You don't have to have a whole male website. In fact, I honestly, you can do it. I honestly don't recommend it because it's a lot of time, and then you have to remarket another thing. The best thing to do is just use your own existing one, and then just have a section for men, and really to have galleries. That's the most important thing. Consistent galleries. Nothing I hate more is when you see like a woman's tummy tuck and she's got like the leopard skin on one side and then the lacy thing on the other side. You just want to people want to see really consistent galleries. Okay, how are we going to make it more male accessible? Do you need an office that looks like Hooters? No, you don't. You just need something that's more gender neutral. It's even more contemporary now. It's not the 80s anymore. Like, so we don't have the chintz and all the flowers. Just keep it more neutral, neutral tones, neutral colors. Get your men's things out. And you also have to know about the body types of men. So men come in 3 different flavors. They come in tall and skinny, like a basketball player. That's ectomorph. Mesomorph is sort of more muscular, and endomorphic is more like a chubby rugby player. So those are the 3 body types. It really helps you when you can talk those body types with the patients and your staff. They know that. And then how do we incorporate them successfully? They're the newbies, they're the people in their midlife crisis. And then everybody thinks, oh, you have this guy, it's like Grant Stevens, right? This guy is a marketing genius. Well, still, even if you're the marketing genius, you can bring on a junior person, a man or a woman, to do all your men's plastic surgery. So there are plenty of different ways to get it into your practice. Let's get into the things that count in 2023. First one is gynecomastia, all right? First thing you have to know is teach your staff, we're not talking about breasts here. Men do not even want to hear the B word. Like, don't talk about it. Nobody wants to be talking about breasts. They are men. They have a chest, they have pecs, all right? So you have to know the nomenclature. For women, it's breast, men is chest, women have breast tissue, men have gyno or glandular tissue, or andromastia, you can even say. Women have an inframammary fold, men have an infrapectoral fold, IMF to IPF. Women have a breast reduction. Don't put on breast reduction for your men's on a men's website or on men's section. I have a men's chest reduction, something like that. Women have a mastopexy. Men, I just made up with the term pectopexy. Go ahead and use it. There's actually a pectopexy for urology terms. It doesn't make any difference. Nobody's going to confuse them. This is what the gyno looks like. 1, 2, 3, and 4. You're familiar with these types. Seems pretty scary, but I'm gonna make it. I have a whole talk about this, but what we're gonna do is we're just gonna really simplify this. For something straightforward, I'm gonna show you just a teeny bit about the clamp strip pull-through method. So you can see what we're doing is I'm not making a big incision, not going all the way around. There's so many gyno factories that really, I mean, they make that long incision, then they pull it out. And TikTok, they take a big blob, throw it across the room. Great, you got 1 million views. Congratulations, and you left the patient with a deficit, with a dishpan deformity. Don't need to do that. You don't need, God forbid, hypertrophic scar or a keloid. So you can You can do it through a tiny little nick incision and do a series of pull throughs. There, I lined them all up. You can see what it looks like. We end up having. So it's all grouped together. You can even send it to pathology if you want. So try and use a nick incision. That'll save, and also set you apart from the other people that use that long one. How do we do our? I'm going to keep a quick clip this morning because we have a lot to talk about. These are the pre-op markings that we do for body banking. So standing photography is so important. You want to make sure that you have that. You mark all the places you're adding to and all the places you're subtracting. These are body banking. We'll get into this a little bit. I use a large cannula. I use mostly in the subcutaneous space. We do some in the muscle. For many years, we pulled away from the muscle as we were waiting for things to develop in Florida to see what happened with all the BBLs that were resulting in deaths. Now I've returned going back into the muscle, a little bit in the sub-Q, a little bit in the muscle. Quite frankly, a lot of it that's in the muscle doesn't show all the way down. So if you can put a little bit in the sub-Q, particularly for the delts and the traps, you're going to get a better result. It's going to be swole. There are ways to make sure the key thing is you want to make sure that it looks natural. I'd say it, but if you only put it in the muscle, it's not going to show, particularly if people have had a lot of weight loss and they have really thick skin. It's not all of it's going to show. It's only if you take those select patients, you put them on a bunch of steroids, put on weight loss, put them all the way to the gym, and show those results in your national conferences where you're going to see all the fat that was injected to the muscle. So that's my philosophy, and it's worked really well for our patients and for our practice. These are different cannulas that we use. The key thing about the injections is you just want to make sure that they're not axillary. They're not, you want to do perpendicular to any of the major arteries or veins. And you want to know your anatomy so you don't actually cannulate any of those. In the history of my practice, knock on wood, I've never had a problem with any of it. Thank goodness. So it's all about being really careful about your anatomy, about your technique. This is what body banking looks like on the table. This is only one of the half of the chest being injected. You'll see the majority of the fat is on the upper inner portion. None of it is in the lower pole. When I use it in the lower pole, you can occasionally to fill it out, but the mistake people make initially is putting too much in the lower pole. They think it's going to look great. They think it's going to be that sexy bodybuilder sort of hanging pec thing. It doesn't. It ends up looking like a man's, like gynecomastia. It ends up looking like a man's breast. What I do is I have a firewall that comes across, a body banking firewall. We inject above, not below, and then the firewall is uninterrupted tissue, so it can't the fat that's been injected doesn't bleed through. Here's what it's going to look like. You get the idea. I get a little excited about surgery, so I apologize for that. Here's the anatomy for the pec major and the pec minor, really briefly. Now we're talking about pectoral augmentation with implants. You can use any company you want. I don't care. But you need to do it. How many people, and well, I think we'll get to this afterwards, how many people have done breast augmentation in a female? I think everybody's going to put up their hands. How many people out there have done a pec augmentation? Even in Beverly Hills, I mean, I'm out in the LA office today. You can see palm trees if I open up the windows. But when we did pec implant, a couple of them this week. When you do them, sometimes I ask the nurses, and the nurses, they've been here for 20 years and they've never even seen a pec implant. So it's really unbelievable. But if you know how to do a breast augmentation, you can do pec augmentation. It's very similar. We're just going to give you a taste of it today, but we do have other webinars and other seminars that have more information about this. It's solid silicone, so you can actually custom carve it, and you can tell your patient that you don't have to worry about any microtexture. You don't have to worry about ALCL. You don't have to worry about really contractures. Really, I've never had one in my career. I guess I've seen it, but it's not common at all. This is what they look like. What's your ideal patient? It really can be any patient. This is just where you want to start. If you're going to start, you want to start with someone that has nice anatomy. You want to make sure it's balanced with the rest of their with their shoulders and their chest, or you can do some muscle grafting into your shoulders and your traps to equalize it. I use the implants because not everybody has enough fat. Usually a lot of the guys, particularly the guys in New York that come in from Chelsea, the guys in LA that come in from WeHo, they're already ripped. They don't have any fat. There's no fat to transfer. They're not these like the women that come in that and other men that come in that have a lot of fat. Some of these guys are ripped. So you need to have implants. Ideal goal is to have good cleavage, and then you usually want to do some grafting on top of your implant to make sure that it's nice and soft. You don't want to have any strong edges. You definitely don't want to have a subclavicular hollow. That is a text mark look of a bad pec implant. So I always taper it. It's always a composite with the body banking on top. And the reason why the fat grafting also is good, because then I can just slide the implant in. I don't have to release all those fibers. That becomes a big bloody mess. All right. So we can just keep it in, keep it bloodless as we put the implant in, and cheat with the body banking or the fat grafting more centrally. All right. Here's this is just out of our textbook. Again, you don't have to take any notes. Here's where you make your incision. All incisions are axillary. When I do I call this the Ziploc incision, because through this incision, I normally can come in at the same day and do a pec, the delt, and either the bicep or tricep implant. Then I'll come back through the same zipper incision and do the tricep if I did the bicep. So there are some people that take 4 incisions to do that. You don't need to do that. You only need 1 incision, the Ziploc incision. And anybody today can email me or call me anytime, day or night, if you have a question about any of this stuff. All right, here's an incision, and I'm sincere about that. Here's an incision. and you go right to the submuscular pocket. So it's actually intermuscular because remember, you're going between the pec major and pec minor. It's going to be a nice sandwich with the implant in between. Dissection through there. There you go. I'm keeping track of time here.
I've got you. Don't worry.
I'm lucky about the back. We want to keep it. So here's our blunt dissection. Not causing any bleeding. We're not releasing anything. We're keeping it blunt, and rarely I have any bleeding in there. You have to tell the patient you may have to convert if you're doing endoscopic, so you may have to convert if you have a bad bleeder. I've never in my career had to do that, but you want to have a bailout. Here's an implant going in. We always yell Taco Tuesday. You can use if you want to, because you fold it like a taco. You can, if you want, you can use I call it the Instagram funnel. You can use the funnel to put it in. I think it's funny because as soon as people put it in, oh, we do it for sterility. The first thing they do is they take the dirty finger and they zip in there and they do it. So what was the point of using the funnel? But that's okay. You can use the funnel. That's fine. I no problem with that. Here's post-op. We're going to use a chest vest. I usually use also foam. I use foam in all my patients. I don't use drains anymore, actually. I have a theory that drains for the pecs and the glutes, if I use drains, then your own endogenous lymphatic system just turns off because somebody left the back door open. So what's the use of doing it? So I've learned that my seroma rate has actually gone down for pecs and glutes now that I don't want to use the drains. And to tell the patients no drains, hurrah, they are absolutely thrilled. So you want to keep your lymphatics working from the get-go. Here's a typical example. Here's an example of how it heals underneath. And even if you do have a scar that's a little bit ropey, it's always, you have some hair around the camouflages. You can tell them to tattoo everything. That's the big thing for men's plastic surgery. Dirty little secret, don't tell anybody, is you can tattoo. Men have no problems with, a lot of times have no problems. I always tell patients, even if there are a 3% chance that you might need a tattoo to cover a scar as a bailout, I don't have a single tattoo on me. I'm too old. But if somebody told me to have an improved contour, there may be a 3% chance that you may want to get a tattoo to cover it. Well, hell yeah, I'm going to go ahead and have that surgery. That is a game changer for men's plastic surgery from women, and also in our society. Now that you have that, you have to use that as to the men to say, don't worry about the scars. You can always tattoo it. Guys that have had massive weight loss on Instagram are tatted up and down. They're fine. There are a lot of people that don't want it, but there are a lot of people that are willing to take that leap as long as they know that bailout. Here's what a pec implant looks like the last guy was a swimmer. This guy is a bodybuilder. There's anterior. Here's a video. All right. Yeah. Get on with it. There it is. Okay. So you can see. You're putting the pecs and shoulders. I like to show videos because people always can show whatever they want with the dark photography and the glazed before and after photos. I'd like to somebody forget to focus, you know. So the next we have scarless abdominal sculpting. We're going to keep with the pace. Here you can use whatever cannulas you want. I just sometimes take power assist cannulas and I bend them. But what you need to do is scarless abdominal healing means not putting any scars on the abdomen. Okay, so I always tell the residents, and I tell people when I speak around everywhere, that I've never had a patient complain about an incision I did not make. Right? All right. If your patient can't complain about that incision if you don't make it. So when I used to do 360 incision all the way around the woman, and she'd have this incision all the way around, and she'd still complain about the 2 drain incisions. So now I don't do that anymore. I do the drain incisions through the 360 incision for all my patients. But it's just an example of how people just really can find something to complain about. Here's how we do our body banking on top. So I don't pump in a bunch into the abs. I only now just do abdominal highlights. That means just making a little puncture with an 18 gauge needle and just going right underneath the skin just to leave a little highlight. People always think when we put it into the abs that they're going to have like big marshmallow abs. No, we don't do that. I've gotten down just to putting just like 5 cc's directly under the dermis. It's a beautiful little highlight, but you definitely have to match it up with your own endogenous uh, abdominal musculature. It'll peek over to the side here. You're going to see right there, you're going to see that's a pectopexy. I'm going to get to that. That's periareolar pectopexy. Okay, what are the things, just going to be brief. You need nutrition, compression, and aggression. That means nutrition means carbs for people to heal and keep all the body banking that you do or the fat grafting that you do in the muscle. You need compression. Foam, these days, foam and compression is so important to your body sculpting. I don't care if you operate on women or men. And then you need drains. You need to get the fluid out, all right? And you need all three of those. Those are the three most important things, not the arnica. The arnica is just there because everybody else has it. Here's just a little freebie. You can see the belly button. I now put a marble in the belly button because if I don't have it, it shrinks down to a little raisin, like a 70-year-old lady that has a tummy tuck. My patients don't want that. I tell my patients that is the cherry on the top of the sundae, put a marble in it. That's just a little freebie. This guy was one of my first patients. This is back when I really used to do more. I've gone way down in how much I put into the abs. Guys still ask for that. A lot of guys ask for this, but most guys want to have just a tiny little highlight just underneath the skin. Here's an example. Is this reproducible? Yeah. I've taught other people to do it, and I get jealous because I look at this result. This is Rocco Piazza. Hey, buddy, down in Austin. Great guy. Say hi to him when you're down in Austin next week. But looks like my patient, so I'm jealous. Here's what our patients look like on the Instagram. They love to show off their abs. Here's a guy that said that he did it all by diet and exercise. Great guy. Here's another video. So this is abdominal highlights. I had to show that video when other people were saying, no, you cannot inject into the abs. Now everybody's injecting the abs. So I just had to show that as proof on video that that patients are happy with abdominal injections. Okay, now we're talking more about body banking. Where do we put it? I'm going to go through these quickly, take it out of the bad areas and put it into good areas. What is catch fat? Catch fat is compensatory adipotrophic cellular hypertrophy or rebound fat. It really does happen. If it doesn't happen, that's because people went down on the postoperative caloric intake or they went up on their postoperative burn rate. So, but otherwise, you're going to get it, and you're going to get it in places that you don't expect. A lot of times it'll be in the flanks, inner outer thighs. Mostly it'll be in as visceral fat. I call these people liposuction cripples. These guys are not brothers. They just had each of them had liposuction 5 different times. Each of them has $1 billion, and they end up looking like the same person on their yacht in Saint-Tropez. You don't want it. You want it definitely. Tonic. So we throw away the gynecomastia cells, and you can see afterwards when you put on weight, the weight goes to the areas that have been augmented rather than the areas less goes to the visceral fat. So that's the other reason. That's how the other thing is I throw on the muscle grafting for free because it adds so much to the patients. That's my dirty little secret. It adds so much to the patient's value and how much they appreciate and how much they tell other people that I'd rather just give it to them free and have them be really, really happy rather than kind of chintz down on it because they're trying to cut down their price. And then they're less happy and then they get rebound fat and then they blame me. so just throw it in. It does take a lot of time. There is a lot of value to it, but it's not worth not having people do it. Here's our body banking back lift. We started just basically finding the value of it and putting it everywhere. This guy is not after, I know you're thinking this is steroids, he went to gym. This is actually like 3 or 4 weeks post-operatively. This is real. So we put it into the shoulders, popped it in the traps, took it out from his flanks. This is an Asian guy that came in from, I don't know, I think it was Taiwan. I can't remember for sure. But you can the back is the new abs. The abs was the old chest. The chest was the old butt. But so the back are the abs of today. So everybody, gay guys, straight guys, who doesn't want a sexy sexy back? Everybody wants it back. We're bringing sexy back. All right. Let's get on to the torso tuck body lifts. So this is a huge thing. This is one of our Ozempic. Ozempic is the game changer, right? It is the Botox. It's even bigger than Botox, right? We know that it's going to be one of the biggest things in plastic surgery. Everybody's happy about it except for the surgeons that do massive weight loss. I'm so sorry. But they had a great run, didn't they? We should applaud that. You know, they really had a great run. But we're going to have a really nice time. We have to get over, a lot of people have an interesting thing about keeping their skin, like that's their badge of honor. But once you get them over that, that's okay. Not semaglutide. We're not gonna use any brand names today. We're talking about GLP. People know what it is. It's a GLP like inducer. So not only was it FDA approved in 2021 for type 2 diabetes, but people saw they lost weight, obviously, and now we're giving it to people who are good candidates to lose it. But this guy's lost 100 pounds, so this is the kind of example of what you can get as a result. He had a fleur-de-lis, but then I did body banking. I put body banking into shoulders, into upper and inner chest, because he did have some fat left over. This is what he looks like on the back. Now, the importance of this picture is placement of incisions is so important. I still see a ton of patients come into my office, and they have this incision that goes way high up because it's a doc that's still doing the 360 body lifts on women or men, but they do it high up on the thigh, like the woman has a French cut a swimsuit from the 80s. You know, it's like, no, that's not the case anymore. And guys, I don't care. People try and talk about structural units of the glutes, and that's why they curve up the incisions. No way. No guy, just because the aesthetic unit of his glute wants to have this big scar that's roaming up and over his jeans or his board shorts. No, get over it. Everybody wants it low. They all want it hidden. So just lower your incision. So that you can see with this guy, incision is nice and low. I do get a lot of patients where I'm lowering the incision. It's hard to do, but I'm lowering the incisions because the surgeon was doing the French cut thing that he's done for the last 30 years in women. Here's what it looks like. You can flip down, do a wallet flip down, use autologous tissue if you want. It gives a nice contour there. And you can use this with grafting, but you have to be careful to make sure the grafting doesn't go through into your incision. This guy already had a full tummy tuck, another surgeon, and so we just redid him a couple years ago. This is when we do abdominal highlights with the torso tuck. So you do a 360, and then we don't make a big honking umbo. We make a nice sexy umbo, and then we add abdominal highlights. So it really raises the bar for our mass weight loss patients. So this is that guy that we did and did some abdominal highlights on him. Here's another guy from last year. Did a torso tuck. You can see by some of his incision disappeared. But then we put it into his chest, we put it into his shoulders, we put it in his traps. So that's a 360 torso tuck with body banking. That's what I call the blue space, where you start to see between the arm and the patient's back in the 3/4 position. It's the patients get a kick out of that. You get a blue space there. This is some triceps. Gonna just kind of finish things off with a couple of fun things. Huge trend in the future is going to be implants. Again, no matter what implant company you use, that's fine. I don't care. It's just a good idea to get these in your armamentarium because not everybody's going to have them. Here's a bicep implant, a couple of before and afters. I have full videos of these that you can see, and we have full webinars, information that I can give you guys if anybody's interested in it, or talk to me down in Austin next week. Calves and quads. These are like uh, we do them anatomically through the medial and the lateral gastrocnemius. I never do it at the same time because I don't want compartment syndrome. I've never had to pull out an implant because of compartment syndrome in my career, because I do it anatomically. Also, instead of putting a big bulk implant in the calf, it looks more anatomic and more sculpted if you have two. These again are semi-solid, so you can use them. You can carve them anatomically. You can bring shape down so they don't project too much in a Shire patient. And you're also going to want to use these for people that have clubfoot or asymmetries, not just for guys that want to look jacked or miss leg day. And by the way, a lot of patients I do are not patients that miss leg day. They just had hit a genetic wall. So we use the two paired ones through the fossa incision. This is what it looks like when you're doing it on the table. It actually just for clarification, the teardrop goes the other way. It goes down into the lower portion. Again, here's a picture. We're using the Instagram funnel so that you can get it into a smaller incision. You don't have to touch things up a little bit. Small incision. It actually takes me to get the implant in. It takes about anywhere from 4 to 6 minutes. And then to close up each leg, it takes about 6 minutes. So it doesn't take a lot of time. And you can do it under local. I did 2 sets of calf implants yesterday. The day before, 2 sets of calf implants, and one was under general, one was under local. There's where it gets results. There's an incision in the back. Patients just love it. That bruise on his shin is not for me. That was from something else. I don't get blamed for that. Patients love them. The quad implants, you would think, oh my God, a quad implant's so big, it's going to take so long. It takes less time to put in than to put in a calf implant. It goes right underneath the fascia. This is ideal. What guys are looking for, more of a bulking of it. I do want to just really quickly. So, okay. Oh God dang it. Just a video shows really briefly how quickly this goes in. I think I can do this. Okay. I'm gonna just jump through this. Oh, forget it. We'll do it next time. But anyway, the incision goes through. It's very simple incision. You go right subcutaneous to the anterior fascia of the lateral quad, and then just right underneath the fascia, and then you put the implant in. So it's even less time than the other implant. Here's what they look like post-operatively. Just a nice little swell. Patients really love them. Then I come back and put it in the medial side. They look fantastic. And so it's something you don't need to be afraid of. Let's get on to the glutes. This is the last thing we're going to talk about before we talk about the ab implants. Men want to have more athletic look versus the Kardashian thing. None of my guys want to have a Kardashian look. Bottom line of this picture is you just want to keep it small. When you're doing glutes, start with a small implant and do body bank or do BBL, do some fat grafting rather. And then as you get better at it, the technique, you can go to this larger implant and go down on the fat grafting until ultimately you can put in a really good sized one because you have the technique down. But don't start with a huge implant. You're just going to ask for trouble. You can put it, I do all mine intramuscular. Okay. This is the kind of patient we're talking about. Has decent coverage, but not a lot of volume. And he just wants to improve that. We go make 2 incisions, go into intramuscularly. I do it all clear, all direct vision with the Bovie. It's all nice and dry. We put the implant in. No touch. Then we Taco Tuesday that in. You can use your funnel and then close it up. We use interrupteds, then running 2 Vico, running 3 over Vico, running 3 monocryl. So patients love the glute implants. Now let's talk. Last thing is going to be about the abdominal implants. These are just for fun. They go underneath the fascia. So a little bit about the abs. They just have a couple extra seconds. There are two incisions. One is through the belly button, and then a smaller one, it's about 2.5 centimeters, is hidden in the shadows of the abs. And then what we do is go underneath the fascia on top of the muscle. It's got to be on top of the muscle because when you flex, you want it to project forward. You don't want to put the implant underneath the muscle. When you flex, it goes underneath, which leads me to just comment on, there's a lot of talk about injecting fat back into the abs. If you do that, and even if you do it with an ultrasound, make sure it's on top, either in the muscle or above the muscle. I've seen a lot of, even in papers that have been sent across my desk for ASJ, people have injected, then they show the MR, look at this, and then on the MR, you can clearly see like fat cyst that's behind the muscle. So when the patient flexes, they flex the muscle and it just pushes a fat cyst into the abdominal cavity, which sort of doesn't do anybody any good. So just be careful about how you do the injections if you're going to do fat grafting to the abs. What do men want? They want to look good. They want to feel confident. And this just shows that a lot of people are interested in this stuff. They want a natural, impressive result that they can be proud of. All right, that's what I find. So in conclusions, they also want not a lot of time talking. When the guys come into our office, they don't shop around. They don't go up and down Park Avenue. They don't kick the tires. They sort of know. If they've seen your gallery, that's what is key. They've seen your gallery. They know that this is what you do. You can do this to set yourself apart from other people in your city, but I really think everyone in every city should be doing this. You're going to have to do this. If you miss the boat, then the other person is going to be doing this, or someone from your office. I don't care if you're a Grant Stevens marketing genius. There's somebody else in your office that you can have doing this. Some Henry Men's down, they have a huge practice down in Texas. They can have another guy that's doing men's plastic surgery. So any practice can have more. It can be serving up men. Guys don't want a lot of downtime. They don't want to worry about incisions. However, they do. They can cover them up with tattoos, and they're more likely to get tattoos than women are. Trying not to generalize, not to be sexist there. Men are interested in edges, not curves. I always jokingly say that doctors, surgeons who deal with women are interested in 4 bumps, 2 bumps in the front and 2 bumps in the back. With men's plastic surgery, I'm interested in 80 bumps all over the place, because that's what men want. That's it for me. I'm really a product of all these great people that are listed there. I'm just this tiny little guy standing on their shoulders. I start to tear up when I think of all the amazing people that have helped me, mainly NYU and Manhattan Ioneer, but a lot of other places along the way. Just want to thank everyone for being with us today, and really appreciate Fedra allowing me to be a part of this.
Thank you so much. That was fantastic.
9:44.
Sweet perfection. Well done. And entertaining to boot. You've shown some amazing results. We're going to dig in with some questions, and I'm going to start the first poll here as well. So if you're still with us, we've got a good group. Please go ahead and take a second to respond to the polls. And then if you have any questions, pop them into the chat box. I'll kick us off here with a few of my own questions while we wait for some to populate there. So you talked, Dr. Steinbrech, about vernacular and breast versus chest early in the slides. So what, in your opinion, is the single greatest advantage of working with men and the single greatest challenge?
The greatest advantage of working with men is they don't they don't they don't beat you up with 1,000 different questions from 1,000 different doctors. When people come into my office, they don't say, well, Dr. Aston said when I was seeing him about my facelift, or Dr. Baker says he's going to do this when he's seeing him with his facelift. And I said, they're much better people than me. Go back to Dr. Aston and Dr. Baker. But so they don't do that because not a lot of people do men's plastic surgery, and so they just say men more like, and I'm really careful not to be sexist and really careful not to be, so I have to be really careful. But I will say that a lot of times I find that that they may be more likely to hire you like a consultant and then let you do it. And all those things I said before, I didn't mean to say that women are that way or that women ask too many questions. I didn't mean to say that at all, at all. And
I think the context was understood.
yeah, I think people understand that. But just people, men are from Mars, women are from Venus, right? So there are some differences. So that is an advantage that I see sometimes, that a lot of times they just want to get back to work and get back to the gym. Uh, the other advantage, as we said before, is they're less likely to have a fear of getting tattoos that would cover scars. So that's a freebie. The challenge for men is they are sloppy. They are messy. They don't follow directions. They faint. The bigger they are, the harder they fall. As
Really.
soon as you take off all their body banging, all their garments, they hit the floor because it really acts like a mass trouser. Like, you remember, if you're in trauma, you put on those mass trousers to keep all the blood centrally, and then when they take it off, they just peripherally dilate and they hit the. Men do not follow directions. You have to be on top of them. They're horrible.
I'm
That's the
sure.
disadvantage
I'm
of
sure
men.
your
Otherwise, I
team
love
is
it.
used to trying to catch them in that kind of a scenario.
Yeah.
So we ran a few polls here, and much as you kind of predicted, 86% had performed breast aug on women and only 14% on men. So probably not surprising.
Wow.
Also looking here, we asked what is the current proportion of your surgical practice? How much is made up of men? Less than 10%, 43%. And 52%, the greatest proportion said 10 to 20%. So still really small numbers. So as you kind of intimated earlier, people need to start learning how to do this because you can't take all of these patients on yourself. And then finally, we asked, have you ever performed PEC aug with silicone implants? And only 24% said yes. So I think that you kind of showed us a lot about the different options of implants. So that segues into my next question. We talked a little bit at the end about the ab implants. So what's the greatest number? You said you'd like 80 bumps. Obviously, you're being facetious, but what's the greatest number of abs that you would place in a patient?
Oh, it's got to be natural. Everybody wants a 16 pack. It's just ridiculous. So I tell people it has to match their own natural anatomy, because if it doesn't, it's not going to make sense. And I in fact, I enjoy when the abs don't line up, because I think it looks really natural. It doesn't look like tic-tac-toe board kind of thing. It even looks more natural. So I always, when people try and tell me to realign them, I won't do it. I have to put them where they line up. And even if you do fat grafting, you still have to put it where they line up, because these guys some of them go back and get in great shape. And if you didn't really stand them up, mark them out, and really get in there to see where they are. And even if somebody has a lot of fat on, you can still get in there and feel where the transverse inscriptions are. Then when they get in shape, they're not going to line up when it starts to come through.
Sure. So next topic is Ozempic. Obviously, this is a hot button topic where there's a lot of different products and drugs on the market. So what has been your experience? It's a relatively new drug, maybe the last year or so. We've been talking about it in kind of the diabetes population, but what's been your impression or experience with patients who are on Ozempic as it relates to their surgery?
Yeah, I mean, from a technical standpoint, a couple things. We have them get off a week or 2 weeks. Some offices do 2 weeks. before they start surgery because of the delay in gastric emptying. I think the anesthesiologist would recommend 1 week. And then the other thing is from the night before, we have them stop eating and drinking from 8 o'clock rather than midnight. So that's another thing because of the delayed gastric emptying. But in general, it's just been, I think, really excellent because we in my office we have always a no judgment. However you're going to lose weight, however you're going to get fit, let's go ahead and do it. So if you're going to do it by a gastric procedure and operation, diet and exercise, if you're going to do it by Ozempic, then why not just go ahead and do it in a safe way. Make sure you do it under the right doctor who understands. Sorry, not Ozempic, the semi-gluten. Make sure you do it in a way that is safely and well controlled. So I think it's fantastic. I'm so happy. I'm more happy about people just becoming more fit and stronger in their lives and having less morbidity and mortality in this world. That's what I'm really excited about. But all along the way, for us as plastic surgeons, it's a new wave for us to be able to offer these people great techniques. But if a guy's gonna lose all that weight, let's not give him, let's not do a technique that's left over from the 80s. Let's not give him incisions that are running up on his backside. So that's where I think we can improve our techniques particularly for men by lowering our incisions. But I think this whole magic injection thing is in general a good thing.
It's not inexpensive, however. So for people paying out of pocket, I've heard it's up to $2,000 a month for Ozempic. So I think that this is that's definitely consideration. Now, going back to the polls, we asked, why do you believe you don't have more men in your practice? And not surprisingly, 58% said I wasn't trained in male-based procedures in residency. So I think this is an ongoing conversation that we need to have about where they can, listen in to experts and key opinion leaders like you in a format like this to learn more. And then we asked, how long do you think the average calf implant procedure takes? And it was split equal thirds between less than 20 minutes, 20 to 60, and 1 to 2 hours. And I think if I was listening correctly, the answer is less than 20 minutes. Is that right?
Yeah, it's less than 20 minutes. I mean, it's unbelievable when I do these procedures because usually they don't have the packages open yet, because they're used to like breast augmentation, this, like, and so the staff is out in LA. There's always like a lot of different staff because it just works differently than New York. New York, we have our regular staff all the time, but whenever there's a new staff member, they just can't believe how quickly that went. So the point of it is these patients can have a really great result. The doctors that are afraid of doing these procedures kind of don't realize that some of them, there is a learning curve, obviously, and we want to do them safely and carefully, obviously. But some of these procedures aren't just quite as difficult as you might imagine them being. And then when you spend so much time in other areas of plastic surgery, mastering your technique of this and this other thing, and there are other things that are right in front of you that is a good opportunity. It's just mind-boggling to me that people don't take advantage of offering these great techniques to their patients, and the patients love them. They love the calf augmentation.
And I love the Taco Tuesday shout out. That's awesome. Yeah. So you mentioned that the back are the abs of today. So why so much interest in backs? And are you seeing men come in asking like predominantly for back, or are they still kind of looking for jaw and abs and calves? And what are you seeing the most?
They're looking for all of it. I mean, still mostly they're looking for abs and for liposuction and whatever that means. And then we start talking about the liposuction is only half of the procedure. And that's one of the things that I always like to talk about in my talks is if you're still in these days, still only doing liposuction and then throwing away fat, I just can't imagine. I haven't in the last 8 years. I think in the last 8-10 years, I think I've thrown away the fat, maybe about half a dozen times, maybe 10 times. A lot of times I refuse to do the case. Sometimes I'll do the case begrudgingly. but I'd say maybe a dozen times max in the last 10 years that I've actually thrown away the fat because I think it's such a disservice. Our team spends a lot of time speaking with people, not to talk them into it, but making them realizing the benefit of it, to not only get a better result to do the other half of the surgery, but also to prevent rebound fat from happening. And it's a real thing. So, but mostly back to your question, people are asking about liposuction and abdominal sculpting, and then the fat grafting along with it. But more and more people are starting to see their new areas, and they're seeing like they want to have a nice broad back. And again, a back is something that no one used to really appreciate. And now with Instagram, people are starting to look with a finer eye, and it's not just like a guy that has a big biceps, a big chest, and then a skinny, scrawny little back. Like you can tell that doesn't look right. You know, the guy doesn't have a balanced physique. And now people are becoming more educated about like what a more balanced physique looks like. And that's
And gotta
where
keep
we
the
come.
gram happy, right? Let's face it.
Exactly.
Okay, we've got a few other questions here in the chat box. So Mohammed Turek is asking, what is the percentage of Simons have he met? I'm not entirely sure what he's asking.
So
And
Simons are they're the difficult patients. So it's single immature male, over expectations and narcissistic.
oh wait, okay,
And
so he's asking how many Simons in your practice do you see?
yeah, we can see them, but I see just as many, Simonettes, which are women that are similar. They're going to be difficult, and I'd say from a percent, a lot of them are weeded out because even our telephone people have gotten a good feel about it. But the people that come in the office, I'd say they're about 3% that we may see. And we, read them the riot act, and we make it clear that this is not going to be connected to a lot of times people come in. I know that I'm going to be a movie star. I know I'm ready to walk on stage and accept my Oscar presentation. No, what I just need one last thing. I just need these perfect abs, and then my career will be made. I will be famous. And we just have to break them down and disconnect that from your old girlfriend, from your old boyfriend, from your new Oscar career. I have one guy that wanted to be Lenny Kravitz. I even turned him into Lenny Kravitz, but I just had to make him know that doesn't guarantee he's going to have Lenny Kravitz's career. But that is really important. And then I ultimately have them, if need be, get a psychiatric analysis before they have surgery. But usually, if I get that far, we try and we try and figure out some way of just saying we don't agree. Our ideas don't agree. But
Understood.
usually we can see them.
In our last 2 minutes, we're going to rapid fire 2 questions at you. So Mina Fayek is asking, saying thanks for the great lecture. And do you inject biceps and triceps fat like pectoralis, and how?
That's a great question. Yeah, I do it. We do it perpendicular. Do it some in the subcu, some in the muscle. Just to make sure. I see people injecting from the arm axilla going this direction. Like it would be so easy to canalize the artery and the vein, no matter how big your cannula is. So just really be careful. I always go perpendicular from here. I do most of it in the subcu, some in the muscle. The key thing with this is to be really safe. I just would hate. I've never had a problem, but it's going to happen if people just do this, willy-nilly. You just have to be really, really careful about it and don't inject too much. The reason why I don't do a lot in the biceps and triceps is because, and you'll get this, injecting fat has as much, I've learned anecdotally, has as much to do about the recipient site as it does about your fat cells. The two main things that I notice about success, three things. Most important thing is carb loading before and after surgery. That is the most important thing. Second most important thing is how old are the fat cells on your body? How old are you? If you're an 80-year-old person, your fat cells aren't going to survive as well as a younger person. If you're a younger person, they're going to survive. And I know a lot of doctors who have had like the fat that they injected underneath the eye, and a person who is younger have asked me, how do I suck it out? And I'm like, yeah, you made a mistake. They over predicted how much fat would survive in a younger person and fat underneath the eyes. So how old you are is the second thing. The third thing is the recipient area of the fat injections. And I'm going to say, you'll get this. I say that the delts, the traps, and the glutes are a tropical forest, very robust, hardy area that loves to have seeds be planted there. The long bones, say the calves, the biceps, the triceps are more like the Sahara Desert, not quite as much. The chest is somewhere in between. So I usually tell patients, first of all, I'm from Iowa. I say, hey, in Iowa we say you can't paint the barn with one can of paint, right? And so I say you got to pick and choose. You got to pick a couple of areas. And I tell them that a good strategy is pick the areas that are going to perform well. Don't waste cells in injecting an area that's not going to accept as many cells survive. So I usually encourage, if they really want everything done, to choose the fat to go into the glutes, the delts, the traps, and then go in with a bicep implant, tricep implant, calf implant. And the way I put in implants is serial. So I'll put in the pec, bicep, and the forearm implant in one setting with the medial quad and the medial calf. And then I can come back any 4 months later and do the other side, the paired. So I'll come back and then do the tricep, the other head of the forearm, and the other head of the calf, and the other head of the quad. And so those are patients that want more implants. But not all my patients, and not most of your patients are going to be like that. Usually, if that is, it's calf implants and it's bicep tricep implants. Point is, I don't do them at the same time.
Sure. And that sort of dovetails with the question here we have about gym and diet. So Sunil Revankar is asking, do you recommend gym training after any procedure? So I think, what's your protocol post-operatively? Yeah. Do you recommend the dietitian consultation for better outcomes? And then he's asking, what is your experience about implant migration? So are they moving?
Yeah. So I recommend the gym, but there are only two areas that I don't recommend overuse. And one is for gluteal implants and pec implants, because they have such a big pocket and can have a fluid collection after a big flood of heavy lactic acid pour from a heavy workout. So for those patients, I tell them, hey, this is the strategy. Look, you came for me a reason. You've been working at the gym for the last 10 years, 3 times a week, 45 minutes a time, and you've put that much muscle on your pec. I'm going to put that much instantly in 45 minutes. So why mess it up by going back, trying to put that much more muscle on what you have is a big lump of meat in there, and put yourself at risk to get a fluid collection. I say use your gym for other parts of your body to balance out your new pec implants and your new glute implants. And they're like, thank you very much. And then that way you don't run the risk of them getting a fluid collection from a big lactic acid load afterwards. Other areas, if we do body banking, or if we do just liposuction or banking in other areas, they can go ahead and work out. They work out after 3 weeks. If they've had a torso tuck, they wait a full 4 to 6 weeks, and then we start them at 40%, get them up to 100% over 2 weeks.
Okay. And then migration.
Migration and implant. Yeah, migration is a thing. You can tell them about a thing. The key things for that is about molding post-operatively. So for the calves, for the biceps, for the triceps, for all these, I put in external bolsters. So that would be like a Curlex or an Ace bandage, and I'll put it on the medial side and the lateral side, so it stays centralized. For some implants, like for the pec implants, I'll put in a figure of 8 stitch, and anybody can call me or ask me about this if you have any questions, just to encourage it. Not tight, because that will cheese wire through the implant. So I make it loose as a tethering suture, just to keep it in place so it doesn't come to the side, so it stays in place, so that the pocket heals. Not a contracture, but the pocket that heals keeps the implant upright during the initial healing phases. And I tell them, listen, implants aren't for MMA fighters. They're not for Olympic skaters. They're not for horseback riders. It's common sense. If you're going to do anything that's going to put a lot of wear and tear on it, then you're not a good candidate for an implant. Implants for people that want to stand at the beach, at the pool, look really good. I think you can still run, you can still do athletic stuff, but people that do heavy jiu-jitsu, contact sports,
Yeah.
are at risk for movement of the implants.
Okay. Honestly, the last question we're gonna in the same speaker here. How long do you place these supports to prevent the migration? So you talked about.
Well, they're internal. The ones I put are internal, so they're there permanently. So I'll use a 4O nylon to put them in, or the ones for the pec I actually do a 2O vicryl. So that's going to stick around long enough for it to stay in. Occasionally, if I do get a migration from one of my patients or another patient, I will do an external securing of the implant. Maybe the bicep implant moved a little bit, or a tricep implant. I do it with internal 4Os, and then I bury them underneath the skin, and they're permanent to hug underneath.
Well, thank you so much. It's been wonderful speaking with you. You've given us a lot to think about, and some fun, entertaining snapshots like marbles and Instagram filters and all of that. Fantastic being with you today. I'll see you in Austin next week for ASPS.
Super excited. Thank you, Fedra, and thanks for everybody attending.
Thank you, everyone.